Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. I will review the updates to the adult and adolescent HIV treatment guidelines from the Department of Health and Human Services. If you aren't aware, they were updated last week. The pediatric treatment guidelines were also updated. I will not be reviewing the pediatric guidelines, but if you treat kids or infants with HIV, please know those guidelines are readily available and were updated. So these will be updates to the adult and adolescent treatment guidelines. I don't have any disclosures or conflicts of interest. This is a list of the sections that have been updated, so I'm not going to review things that have not changed or that we've reviewed in these meetings before. I'm going to highlight the updates and where things have changed. A couple of places I will go into more detail where I feel like it is relevant to everyone, and a couple of places I will note where things have changed, and you can go to this guidelines document for the sections I won't review in detail if they are relevant to your practice or to specific patients. First, here on the left in the purple is the update to the initial regimens recommended for most people living with HIV. I've included in the green the most recent IAS-USA guidelines, which we've reviewed in these sessions before, simply for the sake of comparison. The main update this iteration is that the committee moved raltegravir-based regimens from first line to alternative, basically, or the current wording is regimens for most people with HIV versus regimens in certain clinical situations. So raltegravir has been moved from a regimen for most people with HIV to a regimen to consider in certain clinical circumstances. So here on the left, the recommended regimens are bictegravir with FTC-TAF, dolutegravir with abacavir lamivudine if B5701 negative and no chronic hepatitis B, or dolutegravir with the NRTI's FTC-TAF or FTC-TDF. The Guidelines Committee also included dolutegravir lamivudine with the caveats you can see here, as we've reviewed before. So again, the primary change is raltegravir is no longer present. Comparing these to the IAS-USA guidelines recommendations, you can see they're largely similar, except IAS-USA does not include dolutegravir abacavir lamivudine on their list of recommended for most people with HIV. It's on their list of certain clinical situations. They do also list dolutegravir lamivudine 2-drug therapy as a reasonable option for first-line therapy with a long list of caveats. It seems a little funny to me that dolutegravir lamivudine 2 drugs for initial therapy is on this list of recommended for most people with HIV. We certainly aren't using it that way, and it has all these caveats. To me, that's kind of the epitome of using certain circumstances, but it's on their list for most people with HIV. I think in reality, most of us are not using it that way and are using it more as step-down maintenance therapy once people are suppressed. But that is the primary update to what to start for initial therapy. The explanation for why the Guidelines Committee decided to move raltegravir is summarized here. They make the points that we now have updated data about dolutegravir and neural tube defects. That data is very reassuring. And we now, with, I would say, a fair amount of confidence, can recommend dolutegravir even for people of childbearing potential, and the risk of neural tube defects seems to be much, much lower than we thought with the initial data that raised alarm, and seems to not be elevated compared to efavirenz and non-dolutegravir-based therapy. So the point they make here is that we no longer need to choose raltegravir over dolutegravir for people of childbearing potential. Add to that raltegravir has a relatively lower barrier to resistance. It is not a high barrier to resistance integrase inhibitor like dolutegravir or bictegravir, and there's no single tablet regimen that includes raltegravir. So using raltegravir does have slightly higher pill burden than other options. So for all of those reasons, the change was made. Moving from initial therapy, there were a couple updates to the wording around virologic failure and choosing a new regimen, and I thought this was relevant. This comes up often in clinical practice, often here in our ECHO case discussions. It may come up today in one of our case discussions. And the committee changed their wording. It used to say for patients with virologic failure, a new regimen should include at least 2, preferably 3 fully active agents. The new wording is a new regimen can include 2 fully active drugs if at least one has a high barrier to resistance, for example, dolutegravir or boosted darunavir. And we've discussed cases where this comes up before. If a person needs antiretroviral therapy, frankly, whether they have resistance or not, and they can get one ARV that has a high barrier to resistance, dolutegravir or boosted darunavir, I think, are best examples, then just having one additional active agent seems to be sufficient. In the next slide, I'll show you a couple of examples where I think this comes up and try to sort of translate this into clinical practice a bit more. The other update to the virologic failure section was added info about fostemsavir and clinical information about using fostemsavir for patients with virologic failure and multi-class resistance and using it as part of a salvage regimen. And I'll give you a couple reminders about fostemsavir as well. So coming back to that point, the guidelines used to say, really, we want 3 active drugs. And for years, we often said, okay, we want 3 active drugs in a new regimen. Now we've learned, and now the guidelines have been updated to say that really 2 active drugs is enough as long as one has a high barrier to resistance. So some examples that cross my mind when this comes up, we often talk about cases where a person has an M184V or I, which causes resistance to FTC and 3TC, and I think we have gained a lot of confidence in recent years that in that setting, using bictegravir FTC TAF or using dolutegravir plus FTC TAF or FTC TDF seems to be plenty. Now really that's a little more than 2 active drugs, but you have the active bictegravir or dolutegravir with a high barrier resistance, you have the active or even hypersusceptible tenofovir product, and then you have a reduction in viral fitness from the M184V, which we've reviewed. Another example here would be if someone has an M184V and you prescribe dolutegravir rilpivirine as 2-drug therapy, that's an active drug with a high barrier to resistance in the dolutegravir and 1 additional active drug. We've also reviewed cases here where individuals have extensive multi-class resistance and we pick out 2 drugs that are active with at least 1 having a high barrier to resistance. Here in this example, dolutegravir boosted darunavir as 2-drug therapy is 2 drugs with a high barrier to resistance, and we would be confident in that. Or there may be cases in which a person has resistance across many classes, and we pick out 2 drugs that remain active, ibalizumab and fostemsavir, and then here, because we don't have one of those drugs with a high barrier to resistance, we might recycle NRTIs, we might add whatever we can to make an optimized background regimen and try to get 2 drugs plus whatever we can in that setting. So again, just trying to give some examples and trying to help translate the guidelines, if you will, into something that works for clinical practice. And this is not in the guidelines. This is my own design and my own sort of thinking through, okay, what does this mean for me in clinic? So this is the way I think about designing a salvage regimen. I'd love to hear your feedback on this. Again, not from the guidelines, more my strategy in clinic. So if someone has resistance and I'm designing a new salvage regimen, if dolutegravir, bictegravir, or darunavir are fully active, again, as the guidelines highlight, these are high barrier resistance meds, and someone has a relatively low viral load, maybe in the thousands, not the tens of thousands or hundreds of thousands, or an undetectable viral load, I feel fine about having one of those drugs plus just 1 additional active ARV. In that setting, if they have a high viral load, then I might add another agent until their viral load is suppressed or undetectable, and then drop the other agent, and then I feel fine about it. On the flip side, as I was describing, if someone does not have activity, if there are resistance to these high barrier to resistance meds and those are not active, then I'm going to reach for as many active agents as I can, and then I may try to get all the way out to 3 or more active agents, especially if they have a high viral load. So that's become my strategy and my schematic, if you will, for designing a salvage regimen, but would love your feedback. And I think that largely reflects what the guidelines committee was getting at. I'd like to do a brief review of fostemsavir. Again, the guidelines added more discussion of this as a salvage drug. It hasn't been used a ton. We have reviewed it here, but just want to give you a couple of clinical reminders. It may come up for an individual who doesn't have a lot of other options because of resistance or because of intolerability. I have a couple patients receiving it in clinic, not many. I don't think use has been super frequent, but there are patients out there who need it. So remember that fostemsavir is for heavily treatment-experienced adults with multi-drug resistance, really is used as a salvage medication in most instances. I think the biggest thing to remember is it is an oral medication that's twice daily with or without food, so it is a BID med, which can be limiting for some individuals. And then there are some drug-drug interactions to remember, such as strong CYP 450 inducers, like rifamycins, and then there are some drugs that are increased by fostemsavir, statins, and what's in the package insert is to use the lowest statin dose possible and monitor for toxicity. One, hepatitis C, DAA combo therapy, and ethinyl estradiol. Insufficient use for pregnancy, and the most common adverse event listed in the package insert is nausea. The couple of individuals I've prescribed fostemsavir in clinic seem to be tolerating it just fine. Again, I think the BID dosing is more limiting than any side effects. This data also is from the National HIV curriculum, and from that curriculum and one of David Spock's really brilliant designs here, just a reminder of how fostemsavir works. It is converted to the prodrug temsavir. You can see represented here by the blue boxes. And fostemsavir or temsavir are known as attachment inhibitors because they bind here and prevent the attachment of GP120 and the CD4 receptor. Contrast that, for example, to ibalizumab, the monoclonal antibody, which binds to a distinct site on the CD4 receptor and blocks the same step, but is called a post-attachment inhibitor because of where it binds. And so these are both different than Maraviroc, the CCR5 inhibitor, or enfuvirtide, the GP41 fusion inhibitor. So all the entry inhibitors sort of working at different steps, and fostemsavir is not reliant on tropism or CCR5 versus X4 tropic like Maraviroc is. So that's the brief update on virologic failure from the guidelines. Switching to other topics, they added what I found to be intriguing new language on poor CD4 recovery and persistent inflammation. They have a description about how individuals with poor CD4 recovery tend to have higher morbidity and mortality even with ART-mediated viral suppression. And they have a discussion of a number of strategies that have been attempted to improve CD4 counts in those situations. And the punchline is none of them have worked and none of them are recommended. So in the setting of persistent viral suppression, yet low CD4 count, it is not recommended to add ARVs, to switch ART, or to try things like IL-2 infusions. That has been studied and there was no benefit. The biggest effort in this setting is to address modifiable risk factors for chronic disease, which we all do in our HIV primary care clinics, things like smoking cessation, diet, exercise, and treating comorbidities. They also added this language that in rare instances, people may take their ART, maintain a suppressed viral load, yet have a declining CD4 count because of what they describe as derangements in IL-7 mediated naive T-cell homeostasis. They have some references, but there's not a lot of discussion about what this means or whether it could be intervened on, and this is being actively studied, and hopefully we'll get more info in the future. And we may be discussing an echo case, not today, but in the near future, of someone with declining CD4 counts on ART. So this may be relevant. So please see those sections if you would like more detail. A couple of other sections that were updated: optimizing ART in the setting of viral suppression. This section really adds info on long-acting injectable cabotegravir rilpivirine. I'm not going to go into detail about that because we have had several excellent talks about it recently and excellent discussions about it. But please see this section that has more info if you're interested. I'm also not going to go into detail on this section, but there is added discussion about caring for adolescents and young adults with HIV. I thought it was a very well-written section with a lot of important points and pearls, but for time, I'm not going to go into the detail here. But if it's relevant to your practice and your patients, please take a look at that section. One update that I also found intriguing was an update to this section on cisgender women with HIV. The primary update was a discussion about weight gain that occurs with antiretroviral therapy and seems to be more likely or more pronounced in women, especially women of color. So they've added this language that clinicians should consider the possibility of weight gain in women when initiating or changing ART. And I don't argue that there is good data that that is a phenomenon, that weight gain does occur and it is more likely in women and women of color. The challenge I have is I don't think we fully understand what to do about that yet. And while the guidelines say this should be considered, they don't go into a lot of detail of what that means. And they go on to acknowledge that the underlying mechanisms and the impact long-term on healthcare outcomes is unknown. It is unclear whether switching to a non-integrase inhibitor-based regimen results in reversal of weight gain, and there is significant uncertainty about whether the weight gain we are seeing is a side effect of the integrase inhibitor or the TAF, increasing appetite or causing weight accumulation for some reason, or if what we're seeing is actually toxicity of the older agents. Was it the NNRTIs and the TDF affecting mitochondria and suppressing weight and suppressing appetite more than we realized? So I find it interesting that they added this language, but I don't think we know what to do about it. We've started enrolling here in a randomized controlled trial where individuals who've gained significant weight while on an integrase inhibitor plus TAF-FTC will be randomized to either continue that regimen, switch to doravirine TAF-FTC or doravirine TDF-FTC, and we're going to follow weight, waist circumference, and a lot of other parameters to see if that weight change seems to be reversible. And I think we'll learn more from that study. And for now, I think that the weight change conundrum and controversy really involves a case-by-case discussion with each individual and a consideration for what we know and don't know and helping each person choose the right options for antiretroviral therapy. That's my 2 cents. Would love to hear your opinions. This section on cisgender women with HIV also added, again, updated data from the study on dolutegravir neural tube defects, updated information regarding hormonal therapy and ARV drug interactions, and a new section on menopause in women with HIV. For time, I'm not going to go into detail about this, but those sections are available if relevant for you. The section on substance use disorder and HIV was updated largely to focus on long-acting cabotegravir piperine and largely to state that we really don't know the safety or utility of long-acting injectable cabotegravir piperine for individuals who have a substance use disorder and a history of struggling with adherence to their medications. There is a clinical trial assessing this, and I think we will get more data, but that was really the only update they added to that section. And then finally, an important update to the section on TB-HIV co-infection. The key update to this section is that the Guidelines Committee agrees that 3 months of weekly INH rifapentine can be used for individuals with HIV and latent TB, and that once daily dolutegravir dosing is reasonable when combined with the 3 months of weekly INH rifapentine, as long as the person doesn't have an indication for BID dolutegravir, like dolutegravir resistance. Dr. Shapiro recently reviewed treatment of latent TB in the setting of HIV and drug interactions for ECHO, and that was an excellent talk, and we have that available if you'd like more detail. But these guidelines agree that the options for latent TB therapy include daily INH. Dr. Shapiro talked about some of the considerations around 6 or 9 months, which can be used with any regimen. Once weekly INH rifapentine for 3 months, which is okay with efavirenz-based therapy, or, as I mentioned, once daily dolutegravir, as long as there's no other indication for BID dolutegravir. They also highlight once daily INH rifapentine, though the only ARV combination studied so far with that 1 month, very short course latent TB option is efavirenz-based therapy. They do mention, without going into a lot of detail, rifampin for 4 months as an option with careful consideration for drug-drug interactions. That is a whirlwind through the updates to the guidelines. I'll pause there and see what feedback you have. Questions, comments, things you agree with, disagree with, want to add, or want to ask about. Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.